Sounds good.
Thank you, Abby.
All right, thank you. That was great, guys. Appreciate it. So we're going to move ahead with our sub-I presentations. We had another great group this past month, and I'm looking forward to hearing about each of their respective research projects. We're going to start with Muhammad Ali, who's a student at Mount Sinai. He spent a year, as you may remember, in our department doing a scholarly year in Masters of Science in Clinical Research. Prior to coming to Sinai, he was a student at Cornell, where he studied neurobiology and behavior. He's done projects with a number of our faculty, most primarily though in the vascular division and with Dr. Chowdhury. And he's actually going to be presenting on the topic of vascular disease and Alzheimer's.
Thank you for the introduction, Dr. Morgenstern. Alrighty, so today I'll be presenting on microvascular contributions to dementia. This is a culmination of my work from my time at Cornell, as well as my time as a medical student here at Sinai. These are our disclosures. So when we look at the broad picture of neurologic diseases over the past 2 decades here in the United States, what we see is this reduction in mortality associated with cerebrovascular disease, down from about 60 to 40 cases per 100,000. And this concomitant increase in mortality associated with neurodegenerative disorders. And this project really is at the crossroads of these 2 broad disease categories, specifically how the cerebrovascular system affects cognitive decline. When we look at MRI perfusion for patients with Alzheimer's disease, we see up to a 40% reduction in blood flow, and as well as in mouse models of the disease. And though we know that these reductions in blood flow likely contribute to cognitive impairment, the origins of these mechanisms driving these blood flow reductions remain unclear. That is until 2 recent seminal papers demonstrated that the microvasculature of the brain, specifically capillaries, contribute to reduced brain blood flow. The first out of the Outwell lab at University of London demonstrated that amyloid beta constricts parasites, signals for parasites to constrict capillaries, and that reduces cerebral blood flow. And the second out of the lab I worked at Cornell, where we demonstrated that the neutrophils adhering to brain capillaries lead to a reduction in brain blood flow, which impairs memory function in Alzheimer's disease mice. The way we were really able to study this phenomenon is first by acquiring access to the mouse brain through a cross-sinus craniotomy and then window implantation. And then we used 2 photonic cytofluorescence microscopy to image the brain up to 1,000 microns deep with a resolution fine enough to track the movement of individual blood cells across the length of a capillary. And we see is this, most capillaries are flowing across their length over time, but some capillaries are stalled, meaning that the blood cell here indicated by a lack of textus red dye is not moving across the frame over time. And we see is that in Alzheimer's disease mice, the incidence of these stalled capillaries are significantly greater than in wild-type mice. This is a 300 micron stack of an Alzheimer's mouse and a wild-type mouse, and we see that there's 15 stalled capillaries in the Alzheimer's mouse and only 3 in the wild-type mouse. And then to further characterize what really causes these capillary stalls in Alzheimer's mice, we labeled blood cells, and we found that up to 70% of these blood cells are white blood cells. We knocked out the white blood cells using an anti-Ly6G antibody. This reduced the fraction of capillaries that were stalled, increased the blood flow, improved cognition, and reduced amyloid burden in the mice. However, this is not a feasible strategy in patients with Alzheimer's disease. And so we wanted to try and understand the transduction pathway that increased the likelihood of certain capillaries seeding stalls. So in the literature, what we found was that in a synthetic model of capillary stalling in wild-type mice, that inhibiting the VEGF receptor inhibited the formation of these stalls, similar to how in diabetic retinopathy, VEGF inhibitors are used to reduce the formation of capillary obstructions. And then what we also found was that VEGF levels are vastly dysregulated in Alzheimer's disease mice. So the hypothesis for this project was that if we inhibit peripheral VEGF signaling, we could potentially release stalls and address brain blood flow reduction in Alzheimer's disease mice. And so this project really had 4 cohorts of mice, 2 wild-type, 2 Alzheimer's. They were either given the anti-VEGF treatment or saline injection. They underwent craniotomy, and then 3 weeks after that, they underwent first set of imaging, and then after that, a week after that, they went another set of imaging. And they were then sacrificed, and then further analysis was performed. We uploaded our stacks of images to stallcatchers.com, which is a website we developed where crowdsourced analysis up to 55,000 people analyzed our capillaries for us to determine whether they were flowing and stalled. And what they found for us was that when we give the anti-VEGF injection, the fraction of capillaries that are stalled significantly reduces to about the level of mice without Alzheimer's disease. And then this is associated with a concomitant increase in capillary speed here through line scan measurements. And then the reduction in VEGF levels are associated with a reduction in eNOS and a rescue of tight junction protein occlusion, shown here by a rescue of fluorescence in the Alzheimer's disease mouse that's treated, as well as a reduction of extravasation of the Evans blood-brain barrier leakage dye, the Evans blue leakage dye in the treated mouse. And some of these results were corroborated in human samples of the cortex. And so what we really see here is that in Alzheimer's disease, there's an increase in the level of interluminal VEGF. That leads to increased nitric oxide, which leads to reduction in occlusion levels, which leads to the leakage of toxic material caused the blood-brain barrier into the capillary, which seeds neutrophils, stalls, leading to reduction in cerebral blood flow. And this is really evidence of pathological angiogenesis in Alzheimer's disease, where VEGF isn't accomplishing its goal of addressing hypoxia, but rather leading to further hypoxia. And so some of the implications of this is that drugs targeting VEGF signaling could be employed to rescue brain blood flow reduction in Alzheimer's disease mice and then improve cognitive impairment. But really the next step here is to confirm these trends in human studies intraoperatively, potentially in patients undergoing neurosurgical procedures who happen to have dementia, using imaging techniques such as spectral contrast imaging. Next, I wanted to move on to some of the clinical science work I've done here at Sinai with Dr. Kellner. So interstitial hemorrhage is perhaps the most devastating form of stroke, with a 40% 30-day mortality rate. And in the patients that do survive, approximately a third experience some sort of cognitive decline. Historically, there hasn't really been a effective treatment, though recent developments in minimally invasive techniques have demonstrated an improvement in functional outcomes in patients who undergo evacuation of lobar hemorrhages within 24 hours of last known well. However, cognitive outcomes aren't similarly tracked in these patients, largely because given the difficulty in tracking such cognitive or acquiring such comprehensive data from functionally debilitated patients. So fortunate to receive an NIH TL1 pre-doctoral fellow over my scholarly year to validate the application of a remote cognitive test, a 5-minute test, after surgical evacuation of ICH. That project is still undergoing, but the idea is we hope to see similar trends with cognitive outcomes as we've seen with functional outcomes in our cohort of patients undergoing the stereotactic intercerebral hemorrhage underwater blood aspiration technique. And this technique is pioneered by Dr. Kellner, and it really involves two phases. The first is largely a debulking phase, and the second phase involves active irrigation of the cavity and then targeting of blood vessels to achieve hemostasis intraoperatively. And so what we found is that patients who undergo early evacuation have a much greater probability of achieving a functionally good outcome at 6 months. And in this paper, we demonstrated that evacuation within 12 months had patients who have undergone evacuation within 12 months had almost a 50% likelihood of achieving functional independence at 6 months. Whereas patients who underwent evacuation after 48 hours had a less than 5% chance of achieving functional independence at 6 months. Next, in a larger cohort of 226 patients. So these two studies were done in about 100 patient cohort, and this study was in a 226 patient cohort. And what we found was that early evacuation is not only associated with improved functional outcomes, but a lower probability of prolonged ICU length of stay, which is associated with hospital costs. Next, so after a successful ICH evacuation, there's this residual cavity that's typically left behind. And so next, we wanted to characterize that cavity longitudinally, and to do so, we defined a new radiographic metric, relative cavity volume, which we've from here on out is abbreviated as RCV, and that's defined as the ratio of the post-evacuation residual cavity to the preoperative hematoma lesion. And what we see is this interesting phenomenon that early and effective or high percentage ICH evacuation is associated with a lower 1-year residual cavity volume and better functional outcome. So this is an example of a patient who underwent evacuation within 6 hours. And had a relative cavity volume, just 19% of the preoperative hematoma lesion, achieved an MRS of 2. Whereas this patient underwent evacuation 18 hours after last known well, had a RCV of 57% and ended up having an MRS of 4. And so this is a cubic spine regression model demonstrating that association of a lower RCV on the final CT, which tend to be patients that go early and effective evacuations with a good functional outcome. Next, we wanted to see the effect of ICH evacuation on an edema caused by hematoma. And to do so, we defined another radiographic metric, pericavity edema, which is defined as the edema surrounding the residual cavity after ICH evacuation. And what we found was that high percentage ICH evacuation was associated with a greater change in the edema after the evacuation. This further demonstrating that early and effective ICH evacuation tends to lead to better postoperative outcomes. And whenever we talk about early ICH evacuation, we can't not talk about the risk for rebleeding. And so to better characterize that, we developed and prospectively applied an intraoperative bleeding score, which ranged from a score of 1, demonstrating no active bleeding, to a score of 5, demonstrating active bleeding that required irrigation and cauterization to such an extent that we needed an hour to achieve hemostasis. And what we found was that though at evacuation within 5 hours had a median mean bleeding score of around 4.8, which is close to that max of 5. But then after it sort of drops off to a median bleeding score of 2, which represents minimal bleeding encountered intraoperatively. But even though there was such significant bleeding early on, we didn't see an increased risk, statistically significant increased risk for rebleeding, here measured by the red dots, nor do we see worse clinical outcomes. And so what this really shows is that if you have a surgeon and a technique that is capable of addressing intraoperative bleeding, evacuation at such early time points can potentially be safe and feasible. And finally, the last project was looking at whether the consistency of the clot encountered intraoperatively could potentially affect the technical efficacy as well as the functional outcomes following ICH evacuation. And to do so, we developed another intraoperative scale called the Clot Consistency Scale, and we applied it prospectively in a cohort of about 140 patients. And what we found was that, which ranged from a score of like 1 completely fluid hematoma all the way up to a score of 5 fibrous hematoma with portions that were unresectable even with aspiration or morcellation. And what we found was that preoperative platelet administration was associated with increased clot consistency intraoperatively, and that increased clot consistency intraoperatively was in turn associated with a lower probability of achieving technical success, here defined as the residual hematoma volume less than 15 milliliters postoperatively, which was a standard set by the MSCR trial. And then that lower likelihood of achieving that technical success was then in turn associated with a lower probability of good functional outcome. So I think the conclusion from this study is that, in patients who receive antiplatelet reversal longitudinally, you have to really consider the, in addition to, you have to leverage the pros of platelet administration with the cons of potentially lower technical efficacy and worse functional outcomes. So I just wanted to thank my mentors, my work as undergrad at Cornell with Dr. Schaefer and Dr. Bracco, and then, of course, my work here at Sinai. Dr. Kellner has been such a great mentor the past 4 years. Has helped me, with grant applications, publishing all these papers with him, and then Dr. Mako, who I've gotten to know over the last year, really. And then, of course, the residents and other sub-Is who have helped me on these projects, Alex, Christina, Addison, Dr. Chaudhry, I forgot to mention, who has been a mentor for me in the studying traumatic brain injury. And then the other medical students, undergrads, and even high schoolers who have been part of our lab. Thank you. Take any questions at this time.
Thanks,
Thanks a lot, Abby.
I saw a hand raise from Trevor.
Hey, really nice talk. Nice work. I had a question about some of the dementia work that you were doing. So, did you in your lab think that there's a somewhat of an indolent pathological basis for the development of Alzheimer's? When you were looking at your inhibition, you were using Ly6G inhibition to get rid of effectively neutrophils there, not just white blood cells. Did you think specifically that it was neutrophils instead of doing like a CD45 knockdown to potentially take out other cells, or Ly6C, or potentially like patrolling Ly6C low monocytes?
Yeah,
So I was wondering if you think it's an indolent pathological question is my first one. The second one is, did you look at vascular cognitive impairment specifically as well? So Alzheimer's typically thought of as a very different process than vascular cognitive impairment, which has a different course. So was there any looking at that as a different pathological state?
Yeah, so to answer your first question, what we did was, once we had figured out, so there's another figure that I didn't include in this presentation because of the time limitations, but so this figure uses rhodamine 6G, which labels mitochondria. So we were able to just broadly label white blood cells, as you mentioned, but the antibody we used was the anti-Lyte 6G, which is against neutrophils. So what we did was we wanted to understand which were these white blood cells. So we used the anti-Lyte 6G, and we used a secondary antibody to fluorescently label it, and we saw that most of these white blood cells would happen to be neutrophils. So that's how we identified neutrophils as our target. And then for your second question was about sorry, what was your second question about? Sorry.
Just about, vascular cognitive impairment
Yeah.
is typically thought of as a very separate disease process than Alzheimer's
Yeah,
itself. I do believe that Alzheimer's is has some vascular etiology, but I was wondering if you guys looked at that as well.
So we looked at, we identified traces of this phenomenon in patients with Parkinson's as well as vascular dementia. Not patients, in mouse models, so vascular dementia and Parkinson's. But I think the novelty of this is, as you kind of mentioned, is that there really isn't evidence of such mechanisms driving cerebral blood flow reductions in Alzheimer's disease. So we did see that in vascular dementia as well, mouse models of vascular dementia as well as Parkinson's disease, but those projects are still undergoing right now.
Awesome. Thank you so much.
All right. Thank you, Mohammed. I think we'll move on for time.